I use the concept of personalized alignment, including kinematic alignment, because maybe Chris presented, Chris, that there are many types of kinematic alignment, inverse kinematic alignment, functional alignment. I called include all concept of kinematics alignment and its derivatives, the personalized alignment. Anyway, what is required for TKA? Stability, mobility, pain-free, and durability. So to achieve these goals, we have seeking a better technique, instrument, component, and material. Then we finally achieved good long-term longevity. In most national registry data show that 10-year survival rate is around 95%. And this data is stabilized after 2000. So maybe technique and material are already matured. So this is compared to the previous series. The revision due to the technical skill and the material already reduced. But satisfaction is not perfect. It's around 20% after TK are satisfied. And 1 by 4 patients do not have the same surgery again. And around half patients still have some symptoms, such like pain or discomfort. What do we need more? Navigation or more precise operation or more improved component, such as anatomical design and short interval of the size and improved material. But the improvement of using this one seems minimal. So we should do more. So basically what are the aim of TKA is proper alignment, proper gap and ligament balancing, the proper kinematics. But what is the proper? Maybe this goal is different among the patients. So we don't know what is the final goal. So because the kinematics movement of knee is very complex, the rolling motion, gliding motion, and the rotation, so-called medial pivot motion, like this. This combination is different among the patients. So we should restore the normal patient characteristic of the knee kinematics. The combination is different among the patients. So in a long time, so we aim to the neutral mechanical alignment on the straight leg and perpendicular placement and the component and equal and balanced gap. So this is the one-side-fit approach, systematic approach. But this concept of the constitutional betas is the normal knee. It's not straight in every patient. In average, around slightly betas. This tendency is prevalent in male patients and in Asian patients. In addition to joint line is not perpendicular to the mechanical axis. In average, approximately 3 degrees medially inclined. So this is the concept of joint line obliquity. So it's now focused on. So if we set the same level at the lateral joint line. Medial joint line can increase if we set the joint line the medial side. Lateral joint line can decrease. So using the mechanical alignment, joint line can be changed after the operation. That can cause some discomfort or conflict in terms of kinematics. So if the joint line increases, that can cause mid-flexion instability. Furthermore, in the most surgeons aim to the balance gap in the extension, the flexion, and equal and parallel gap. But in most patients, the lateral is more lax than the medial side. And this lateral laxity is different among the patients. So we don't know which amount of lateral laxity is proper. So this is a change of a concept. This is a custom fit TK. This is the original form on kinematic alignment reported by Howell in 2008. Using the PSI, custom fit instrument, to restore the patient's original articular surface, implant the component along the original patient's original joint surface. Then it is improved to the kinematic alignment, TKA, that is a true resurfacing surgery. The component implanted along the three kinematic axes is the flexion axis of the tibia, and the flexion axis of patella, and the longitudinal rotation axis of the tibia. So this is the basic component of kinematic alignment. This is the calipered kinematic alignment. This is the true, also called as true kinematic alignment. This is a true measured resection. It cut the bone in the same thickness as component. Distal femur, and the posterior femur, and the proximal tibia. Compensating the cartilage loss. In the distal femur, in the cut the lateral condyle, it affected the lateral condyle as 9 millimeter, but the medial side, the compensating for the cartilage loss of the 2 millimeter, the cutting thickness should be 7 millimeter. And the posterior femur is both sides is 9 or 8 millimeter. It depends on the thickness of the posterior condyle of this component. And similarly, the TV proximal tibia, the lateral side is 10 millimeter, and medial side is 8 millimeter, compensating for the cartilage loss, the 2 millimeter. So, finally, kinematic alignment respect the patient's own alignment, so-called constitutional alignment, and patient native joint line. So, constitutional alignment and joint line obliquity is different among the patient, but in this approach, the native alignment can be respected. But there are two questions. What is the original joint surface? In this, some patients have severe bone loss like this. So in this patient, we can find the original articular surface, and especially in the Asian patients have the very extreme alignment, such as two severe varus alignments. It is something different from the Western countries. This is a classic data. If you implant in the two varus or two valgus, that can cause a higher rate of revision. But this data is based on the mechanical alignment. So if we aim to the mechanical alignment, the alignment outlier also causes imbalance of soft tissue. So we cannot naively to interrupt this data to the kinematic alignment. Anyway, we are worry about the outlier in terms of component and or leg alignment. But in the Western countries, up to 10 years, alignment, the total leg alignment and the component alignment doesn't matter, as long as follow the true kinematic alignment concept. A 10-year survival rate should be 98% up to 10 years, regardless the component and leg alignment. And the previous natural registry data is similar data, is unrestricted kinematic alignment as all other technique. The survival rate should be similar up to 7 years. But worry about the alignment outlier, the restricted kinematic alignment can be used. In this approach, kinematic alignment cut is made within the safe range. Otherwise, the cut defines the angle. So, but this restriction boundary is different amongst the author. Roughly saying around plus minus 3 or 5 degrees. But there is no evidence to define these boundaries. So maybe I believe this boundary is different among the races in Asian countries and Western countries. Maybe we need to some evidence. What is the true boundary? What is the true safe range we get to get the good longevity? Oh, this is Japanese data, our data in terms of MPT, tibial joint line and femoral joint line LDFA. In the most patients, in terms of the tibial side, most patients out of plus minus 5 degrees. Around half patients have more than 5 degrees imbalance in the tibia side. Or if we compare to the Western data, this is the data from the Canada. Is both tibia side and femur side is 6 to more balance. So we cannot interrupt the previous published data to the Asian countries. So we need to reconsider what is the angular limit to get the good longevity and good term result. So if we adapt the restriction to the Japanese patient, most Japanese patients requires restriction. In our study, around 80% requires restriction using the previous reported restriction kinematic alignment boundaries. So I don't know, we can follow this restriction boundary or ignore and naively do the true kinematic alignment or not. We don't know, we have no data. But the problem is, to do the kinematic alignment, we need a computer device such as PSI, robot, or navigation. So I devised to the mechanical-based kinematic alignment. I measured lateral malleolar axis is up. I'm sorry. Okay. I measure angle between the tibial mechanical axis and the line between the knee center to the lateral malleolus. This angle is in average 5.5 degrees in the average. So if the extramedial lot not exceed to the lateral malleolus, the tibial varus angle should be less than 5 or 6 degrees. Using this mechanical-based restriction protocol, So this is a preoperative variation of MPTA. After the operation, most of patients is within the safe range, within the less than 5 degrees in Vedas. So we can roughly use the lateral malleus to do the restriction for the tibial side. And similarly to the femoral side, we naively cut the lateral side is 9 millimeter and the medial side is 7 millimeter, compensating to the cartilage loss. That is considered to be the 2 millimeter. But some patients have the bone loss. Not only the cartilage, but also bone can be lost. So we cannot know the amount of bone cut. But previously, in the pre-operative X-ray, sometimes we want to correct not only the femur side, but also the femur side. For example, some patient has too severe varus in the LDFA. Then normally LDFA should be the 3 degrees in valgus, but sometimes 2 degree or 3 degrees varus preoperative X-rays. In such patient, we need to correct not only the tibia side, but also the femur side. So to correct the femoral side, so I insert thin metal plate between the plate and bony surface. If we insert a 1 millimeter bone plate, we can correct approximately 1 degrees in the varus and valgus alignment. That can also be used for the restriction, make the restriction using the caliper without a robot. So this is a problem. So even the LDFA is have the very big variation preoperatively. And if we cut naively, so the same thickness, compensating for the 2 millimeter for the cartilage loss, the distribution of LDFA is similar in the preoperatively compared to the preoperatively. We should correct the femoral side as well if we do the restricted kinematic alignment. This is next topic of the kinematic alignment. This is to know the patient original characteristic of the alignment. There is a 2 alignment. The one is the 4-leg alignment. This is calculated with arithmetic HKA. This is MPTA minus LDFA. This is simulate. It shows the patient native alignment. And joint line obliquity. This is calculated with MPTA and LDFA. And then using this one, we can classify the patient phenotype into the 9 categories. But in Japan, around 6% have the varus leg alignment, and apex distal, the medially inclined joint line. But this percentage is quite different from the Western patient. Western patient, this category is not so many, like this. So distribution is basically different. This is Australian OA patient. The distribution is quite different. After the kinematic alignment, using the modified restricted kinematic alignment, in the percentages of this category, is reduced after the restricted kinematic alignment in our hospital. Of course, this tendency is similar in the Western countries. If we naively do the kinematic alignment, through kinematic alignment, this percentage cannot be changed. So this is a worry about the outlier. In Japan and some limited countries, soft tissue respecting kinematic alignment is used. It is very simple. Cut the distal femur and then cut the tibia parallel to the distal femoral cut, like this. Then draw the line on the tibia surface and cut the parallel to the distal femoral cut. This is another technique for this soft tissue respecting kinematic alignment. After the after the distal femoral cut, set the femoral trial and measure the medial gap, applying the vertical stress, and measure this space using the special curved gap gauge. So using this one, we can accurately calculate, measure the space, this one. And then, using the two styluses, if we can insert a 3 millimeter curved gap gauge, then set the cutting thickness lateral side as 10 millimeter and the medial side as 7 millimeter. If this space is 5 millimeter, lateral side is 10 millimeter and medial side is 5 millimeter. So using this one, we can adjust the cutting, the thickness to get the good balance in terms of extension. So using the computer, we can more accurately can balance the gap, so-called functional alignment. This technique is based on the intraoperative measurement by the robot, such as leg alignment and laxity. Using the robot, we can get the laxity in the extension flexion and mid flexion and deep flexion. Using this data, we can manipulate intraoperatively and get the good balance. So this approach is basically focused on to achieve the good balance throughout the motion. So this technique is basically used for the PS, or both PS and CR, because the gap is balanced interoperatively. So this is another derivative of kinematic alignment. The inverse kinematic alignment already shown by Chris. So cut the tibia the first, then decide the femoral cutting angle is based on the tibia cutting surface. This approach also requires computer navigation, but this approach is quite similar to the gap balancing technique of the mechanical alignment TKA. This is the adjusted mechanical alignment. In the field of mechanical alignment, some variation of the alignment can be allowed because this is based on the data. So minor undercorrection of HKA acquires better results than strict mechanical alignment. So minor undercorrection, minor various alignment can be allowed and even acquired good clinical results. So using this data, is minor undercorrection can be allowed plus minus 3 degrees. So this approach also requires computer devices. So although we can use the many types of kinematic alignment. So if we use the term of the kinematic alignment, some contradiction or some misunderstanding can be allowed. So I use the term of personalized alignment in contrast to the instead of kinematic alignment. So mechanical alignment, again, aims to the neutral leg alignment and mechanical component alignment and the balance gap. But the personalized alignment, so respect the patient-specific leg alignment, patient-specific joint line, and patient-specific joint gap, especially in the flexion gap. Flexion gap is looser than the medial side in most patients. So this is a one-size-fits approach, a systematic approach, aiming the single goal. But goal is different in this personalized alignment approach. So personalized alignment includes true kinematic, restricted kinematic, and functional alignment, inverse KA, adjusted MA. But other than true kinematic alignment, we require a robot or some computer devices. So this is my theory. There are three main important elements of the knee. One is the morphology and soft tissue alignment. So they makes a good harmony. So one element decides other two elements and decided by other two elements, and constructing the patient's own kinematics or harmony. So approach is different. If you respect the morphology, that is the caliper kinematic alignment, but finally, we can achieve the same goal. If you rightly do the true kinematic alignment. So this is a soft tissue respecting. If you set the implants, so respecting to the soft tissue balancing, if we achieve the perfect soft tissue balancing, so morphology and alignment should be restored the patient's own situation. And this approach is alignment. First approach should be restricted kinematic alignment, but aiming the same goal, but approach is different. And using a robot, we can manipulate the all elements in the same time. This is so-called functional approach. So this is my approach. Is the preoperatively, I simply measure LDH, MPTA, and calculated arithmetic HKA. Arithmetic HKA is implies the patient constitutional HKA. That is the goal of the patient on postoperative leg alignment. Then decide the cutting angle and cut the femur as planned. Sometimes I make some restriction to the set the LDH 5 degrees in valgus to the 0 degrees in beta. Then cut the femur as planned and then cut the tibia. There are the two options. So the first option is restricted kinematic alignment. They decide the tibia cutting, cut the tibia as planned. The second one, decide the plane, tibia cutting plane based on the laxity. This is so-called functional alignment. For example, preoperative data such as LDFA 89 in this patient, I set the LDFA as 87%. MPTA is 2 beta, so I reduce the MPTA angle as 5 degrees in betas, as posterior tibia slope up to 7 degrees. And using this plan, the final HKA should be 5 degrees in betas. That can be accepted. So femoral cut is made by this planning. Tibia cutting angle is 3 degrees in betas, and cutting thickness is 2 millimeter thinner in the medial side, compensating for the cartilage loss. And cut. Then posterior femoral rotation is parallel to the posterior condylar axis, PCA, in the same thickness as the component. Then tibia cut option 1, following the restricted kinematic alignment, and planned cut the tibia cut the tibia as planned, 5 degree in varus. In this patient, the cutting thickness is 2 millimeter thinner in the medial side. But sometimes, after the tibia cut, gap is imbalanced. So this laxity is measured by robot or tensor device or spacer. If in this situation, so there are 3 options. In the most, it's similar to the mechanical alignment. If we cut the tibia and the femur, for example, perpendicular to the mechanical axis, this gap space should be trapezoidal, like not parallel. What should we do next? This is a very important question. We have 3 options for manipulate this trapezoid gap. One is release the medial collateral ligament, MCL. So this is a mechanical approach to make the rectangular gap release the MCL. This is one approach, but that causes the pain or instability. So I want to avoid the release the soft tissue. So another one is the accept the trapezoid gap, so-called medial preserved gap technique, for focus only the medial side gap, and lateral loosening can be ignored. So this is another approach. The third approach is the cut the parallel to the joint line. This is a kinematic alignment concept. To respecting the soft tissue balance, so the bone cut the line is decided based on the soft tissue balancing. So if after the first cut, the balance is not accepted, we can recut, manipulate the cutting angle, increase the tibial varus angle, and recut using a robot. So recut using a robot is very accurate and very easy. And the second option is to manipulate the cutting plane on the screen. In the current robotic system, if we manipulate the cutting angle and cutting thickness and the estimated gap balancing, this is the sum of bone cutting thickness and the soft tissue laxity can be displayed on the screen. Then referencing to these values, we can manipulate the alignment of the cutting plane and thickness of the bone cut. Then another one is manipulate the tibia cut plane on the screen, but now we are focused on the stability of the extension. So intraoperatively, I measure the stress, the HKA, apply the valgus stress angle, and measure the HKA intraoperatively. This should be the target of the final HKA. So this time is already femur is cut. So calculated using this estimated valgus angle stress valgus HKA and distal femoral cutting angle, I calculated the tibial cutting angle. Stress equate the varus, but we cut the distal femora in the 2.5 degrees in valgus. So to make the total postoperative leg angle at 3 degrees varus, we need to cut 5.5 degrees in various for the tibial side. But using my computer, the various cutting angle should be less than 5 degrees. So I set to the 5 degrees in various. Then we can get this target HKA post-operatively. This is the take-home message. Personal alignment is to set the components set along the joint line to restore the patient's native joint surface. Restore the patient native alignment, soft tissue balance, and patient native morphology or joint line. Goal is very different among the patient. We need to find the patient's best goal individually. This is the personalized approach. The contrast to the MA that is aiming a single goal. So our new technique is aiming to the patient-specific goal. That's all. Thank you for your attention.